So the brain, cranial nerves, and I'm going to refer to this as Homer Simpson because of his massive brain. Okay. Okay, here we go. The nervous system. Blah, 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 right? You're sick of this picture, all right? Don't be surprised if some question comes up on here for the final exam, right? Because you've seen it so much. But it's just, again, showing you in the scheme of things where we're going to be talking about, okay? Really, it's doing a lot of things, but this is what we're really concentrating on. And you can see it like this and like this, okay? You know, 4 slides right under your belts. Even this is a repeat, okay? But I want to show you again. This central nervous system is the brain, which has 3 parts to it: the cerebrum, the cerebellum, and the brainstem. Then we have those 2 scary words, right? We have the diencephalon, and we'll be talking about that a little bit later today, which deals with all the thalamuses. So you have the thalamus, the hypothalamus, and the epithalamus. You also have mammillary bodies that deals with memory, and also something called the pineal gland or the pineal body, which is going to be a part of the endocrine system also. Then the other scary word is the basal ganglion, right? This is the stuff that's going to control unwanted movements, but it's also going to help initiate movements and help terminate movements too. Substantia nigra we're going to talk highly about. That's dealing with like Parkinson's. We have the caudate nucleus, globus pallidus, taenum, claustrum, and amygdala. Okay? And then we have the spinal cord, which you know everything about. So I'm not going to go into that. All right. The brain. Looks like a boxing glove, as you've seen before. Now here's some generalizations of brain. This is new stuff now. The major parts: cerebrum, cerebellum, and brainstem. It weighs about 3 to 3.5 pounds, except for Homer, right? But that's okay. 83% of the brain volume is in the cerebrum, but as I told you before, 50% of the neurons in the brain are in the cerebellum. Okay? There are no pain receptors on the brain. Ooh. That means you could do surgery on the brain and they don't even feel it. And you've seen this on TV and documentaries. Now don't get me wrong, they can feel pain on their scalp, their bone, even the meninges. But once you get down there, if all that stuff was anesthetized, the brain itself, there is no pain receptors. And that's a useful thing for surgeons to do. Because if they have to burn a certain area of the brain because it's causing convulsions and seizures, they want to make sure that they get that particular area, and they want to they don't want to make sure they want to make sure that they're not going to burn other areas around it. So they're going to be touching on certain parts of the brain and asking the person who's awake during the surgery and says, okay, and make them read a card or show them something in front, like car keys. What is this? And they say pencil, and the doctor's touching that area. Whoa, it's too close. We got to let go of it because it's affecting that. You see what I mean? So it's going to help map out where they have to do any kind of surgery. Okay? Overview of brain functions. The cerebrum is going to do cognition, the thinking part. And again, that's the wrinkly part. So you have cerebrum, that's the wrinkly part. It's going to control the thinking stuff. We'll get into all those a little bit later. It's going to also receive sensory. You learned about that with the Postcentral Gyrus. And it's also going to send out voluntary motor function. And we dealt with that too when we talked about the Precentral Gyrus. The cerebellum is going to be the one involved with balance and coordination, amongst other things. And the brain stem, well, that's the thing that's going to control all our vital stuff. Blood pressure, respiratory rate, heart rate, that kind of stuff. the area where, well, this is the foramen magnum. Once the brainstem passes the foramen magnum, it's now known as the spinal cord. So it kind of tapers off to that. All right, so you've seen it. There's our cerebrum, cerebellum, brainstem. We'll get to see those when we dissect the brains and the models later next week. All right, brain regions. This is a sagittal cut into the brain. Okay, the diencephalon is really the center part of the brain. Okay, the cerebrum is this bluish area. The cerebellum is this area in the back here, and this is the brainstem. The nose is here. I kind of drew it the opposite side. This is looking at the medial side of the left brain. That's the lateral side of the left brain. Okay. Now, two other directional terms: rostral and caudal. We dealt with rostral or caudal before. Oh, right. Just notice it looks like bad grammar here. This is towards the forehead. This is towards the spinal cord. I gotta fix this. I just realized that. I'm like reading this. So basically what we're saying here, this is going to be rostral. This is going to be caudal. Okay? Nothing really to matter. Wish that all your tests were going to be like this. All right. So again, it's just showing you rostral and caudal. Okay? All right. Some other things just to review very quickly. Your brain actually has two what we call hemispheres. You're looking at the top view of it. You've got the left hemisphere and the right hemisphere. In between, there's going to be this fissure, which is a deep sulcus. We call that the longitudinal fissure. It's going to separate the right and left hemispheres. The sulci are all these crevices that you see here. The gyri, or the gyrus, each gyrus, is the bulge. The cortex is the outer gray matter of the brain. And the nuclei are deeper masses of gray matter that are found scattered in the white matter. And the tracks that you learn going up and down are going into the brain itself, and that's the white matter. So, cerebrum, the largest part of the brain, the folded brain, right? The folded area. Why does it fold up? It folds up because the gray matter grew faster than the white matter. That still doesn't make sense. Well, the skull is there. So what's going to happen is the gray matter is going to grow faster than the white matter, so the gray matter can't expand further than the skull, so it undulates on itself. Does that make sense? It has no place to go. So it kind of undulates, and that's why you're seeing this so wrinkly here. Okay? There's a picture that I have in one of your the labs here. Let me show you. This one. Yeah. See this alien? All right. You didn't think I would be talking about aliens coming here, right? You see how like there's all wrinkles on his brain? Okay. This doesn't make any sense. Because, like I said, the reason why ours have wrinkles is because there's a skull there. So it undulates on itself. There's no skull here. So this would have been growing bigger and bigger, and this would have been all smooth like a baby's bottom. Does that make sense? It doesn't undulate. Now, I don't know much about alien embryology, okay? but I mean, I guess maybe this is where you get these, people in science fiction and stuff. Maybe in the embryology, maybe it started off having a skull, and then when you're born, the skull comes off. I don't know. Okay, they molt or whatever it is. But I'm just telling you, from this picture here, this wouldn't make any sense. Okay, does that make sense to you? I guess. Okay, I won't ask you about aliens, but I just want you to be pretty knowledgeable on that stuff. And then, of course, you can imagine what I'm like with family members. Like, can't you just enjoy the movie? Why do you have to talk about, this doesn't make sense and stuff? So, anyway. Okay. So anyway, that's about the gray matter and why it's shaky or wrinkly like that. The cortex, the outer gray layer, the cerebrum, there's two halves that I explained, two cerebral hemispheres, the right and the left. Now, the only place that the right and left hemispheres communicate with each other is an area called the corpus callosum. That's the only place. I'm going to show you what that is. That's going to link. It's a small piece of tissue, neural tissue, that connects the right and left hemispheres. And that's where things can cross over where the hemispheres are. If we do a coronal cut of the brain here, okay? So there's one hemisphere, here's the other hemisphere. This is the diencephalon. This is not part of the cerebrum. But there's the cerebrum, there's the cerebrum. The only place we have a connection is this little band here. That's the corpus callosum. It's the only place that we have nerve fibers going here to this side and this side over here going this way. The only place. Okay? It'll be right above, you learned about the ventricles. Or you should have, right? Read about it. But those are the ventricles over here. A few other terms. The median or longitudinal fissure, right? I talked about the longitudinal fissure separates the two hemispheres. But like in all anatomy, you got to learn to say one structure about two different ways. They sometimes call it as the median fissure also. Same thing. There's coverings around the brains. They're called the meninges. When you read the Frankenstein thing, it explains it. They're coverings. There's three coverings. The outer covering is called the dormata. The dormata will come over here and goes into the longitudinal fissure. That part of the dormata going in is called the false cerebri. Okay? That's where that is. It's the extension of the dormata going into the longitudinal fissure. We also have the lateral sulcus. That's going to separate the temporal lobe, which is the thumb, with the frontal parietal. It's that there. We also can call it the Sylvian fissure. Same thing. Okay? So the Sylvian or lateral sulcus or the Sylvian fissure is right here. Okay? We also have the transverse fissure, and that's going to separate the cerebellum with the cerebrum. Okay? Not too bad. Okay. So there's the mid-sagittal view of the brain. There's our lateral ventricle, the hollowness that we have. It's filled with cerebral spinal fluid. Just above it is our corpus callosum. That's the only place. Because now you're looking at, before I looked at a band, but that was a coronal cut. Now we're doing a sagittal cut, so we're looking at a different angle. That's the only place that the right and left hemispheres can communicate with each other. Okay? There's our cerebellum, there's our brain stem. Okay? Looking underneath the brain, the inferior portion of the brain. There's the temporal lobe, the thumb, and here's the other temporal lobe, the other thumb. This is going to be your brain stem. There's three parts, the midbrain, the pons, and the medulla oblongata, which leads to our spinal cord. We'll get into that. Here's the cerebellum. It has two lobes there also, one there and one on that side. When you get into eyes and ears, you'll see that there's a little X here, and you'll see them on the brains. It's called the optic chiasm. Where the optic nerves cross over, it goes to the eyeballs, they kind of cross over like that. see that there. You also see these two long things going towards, or become rostral, we can use that term. These are olfactory tracts leading to the bulbs. They actually will go down into the ethmoid bone, the cribriform plate, and have nerves going down there into the nasal cavity. Olfactory means smell. Okay? This is still the coronal cut. It's just of a real brain instead of cartoon. So you're making a coronal cut here. And again, there's your two lateral ventricles in a different angle. There's our corpus callosum, connecting the two hemispheres. You could also appreciate, I guess, it looks better on the computer, but you got the gray matter surrounding the white matter. Gray matter that's all on the perimeter here is also referred to as the cortex of the cerebrum. This is what our brain looks like at 30 years old. This is what we have to look forward to at 70. The sulci get wider and deeper, and the weight gets less. That's why people are not with it later on, all right? But we'll talk about that later too. So, the four lobes, frontal lobe, parietal lobe, temporal lobe, and occipital lobe, they correspond to our skull bones. But there's a fifth lobe. You can't see it here. You have to actually take the temporal lobe, pull it down, and the frontal lobe and pull it up. It's found in between there underneath. It's called the insula lobe, also known as the island of Real. Okay? So you can't see it. It's deep to the lateral sulcus. I'll show you what it looks like. The central sulcus, right? We talked about that. Separates the frontal and parietal lobes. So you have the central sulcus over here. This is the frontal lobe. This is the parietal lobe. Temporal lobe. I'm losing the colors here. And occipital lobe. Precentral gyrus, just for review, that's a sulcus, it's a crevice. The first gyrus that's anterior to that, this right here, is known as the precentral gyrus. That's going to control or send cortical spinal nerves down to control motor. We have the postcentral gyrus, the one right behind or posterior to the central sulcus. This over here, that's part of the parietal lobe. This is the postcentral gyrus. And that's the one that's going to collect all the sensory from all over your body. Okay? So frontal lobe is here, parietal lobe is here. You could definitely see where the central sulcus is. You could also see the first gyrus in front and the first gyrus behind. And you'll see them in models. Okay? Whatever model at your school you have, but you'll see the central sulcus, precentral gyrus, postcentral gyrus. You should also have an understanding of what they're responsible for in terms of motor versus sensory. So So where's the insole lobe? Well, like I said, you got to take the temporal lobe and the frontal lobe and kind of pull it apart like that. That's the insole lobe. And again, you can see a reiteration here, the central sulcus and the postcentral gyrus, precentral gyrus. Okay? Some functions of each one of these lobes. The frontal lobe does the thinking part. It's also the one that's going to control skeletal muscle, which you already know because that's the precentral gyrus, which is a part of the frontal lobe. It does planning, a mood, and smell, and social judgment. The parietal lobe is going to take care of all the sensory, because that's where the postcentral gyrus is located. So you're going to think of temperature, touch, pressure, vibration, even taste, which is anything gustatory means taste. Sensory. Occipital lobe, kind of a weird thing. It's all the way back here, but it makes you interpret vision. Interpret vision. If you have a stroke to the occipital lobe, are you blind? What does it mean if you have a stroke to the occipital lobe? How will the person present? It does. Correct. You show this to someone who had a stroke to the occipital lobe. Ask him what it is. It's a dog. What do you mean a dog? Yeah, see the ears there, the tail. You see what I mean? You're right. They're not blind. They just don't interpret what they're seeing. This is going back to my style of teaching, okay? Many teachers like to say, here's a list, make sure you know what they do. And that's just rote memorization. But you guys are going into the medical field. I don't care if it's physical therapy, occupational therapy, nursing, doctor. If you're an occupational therapist and you know they had a stroke to the occipital lobe, don't be surprised if they call you the fireman. Do you see what I mean? Don't be surprised that you said, please pick up the shirt, and they pick up the pants. Do you see what I'm saying? You're going to have to appreciate what's going on. I wouldn't say so much respect, but yeah, respect the person, but appreciate it. I want you to, as I've always said, don't memorize for the sake of the exams. Don't ask what's going to be on the exams. Ask how you're going to use this for your future. If that's so, and you study for your future, the test will just fall into place. You know that's how I ask questions, at least over here. Right? I'm not going to say, what does the occipital lobe do? No. I expect you to come in with that knowledge. But I want you to know if the occipital lobe was removed, how would the person present? Which is the same thing as a lot of other teachers would ask. They just ask in a different way. What's the function of the occipital lobe? Oh, to interpret vision. But how do I know if you really know what that means? Then remove it. And how is that person going to see? Get your mind wired for clinical thinking. Some people call it critical thinking, but I call it clinical because you're all going in the medical field. You should be thinking that way, how to apply it. Because rest assured, you'll be able to remember this when you put all these kinds of diseases in there. Okay? Question? Tumors are kind of a weird thing because they may increase or amplify certain things, or it may destroy it. It depends on how it's growing and how it intertwines. It usually will destroy it because it's getting bigger and pressing on things. Have you ever seen the movie Phenomenon with John Travolta? All right. Interesting movie. I don't want to spoil it for you, but he ends up doing a lot of things, and they thought he was an alien, but it turns out he had some organic thing going on with him because of that, because things were being amplified. He's able to move things with his mind. He could use his brain that other people couldn't. Another more recent movie that maybe you've seen is Lucy. Have you seen that with Scarlett? Yes, Scarlett, where there was some kind of drug that was put into her body, and it broke. She was supposed to transport it from one country to another to smuggle it in. It broke, and it went all over, and it amplified everything in her brain. She was able to move things with her mind. She was able to memorize things. She could do where you could actually communicate by just with the mind. You could turn TVs on. Could actually do surgery on her, and she's reading a book because she has a way that you could. The reason why, think about it. The reason why we need anesthesia is because you can't deal with the pain. But she used her brain so much that she turned off her pain receptors, and they were able to do surgery. They didn't need to do the anesthesia. So what they're trying to show in that movie is how much of the brain you could actually use that we're not using. They always say, well, we only use 10% of our brain. That's misleading, because how do you know if we're only using 10% of our brain if we don't even know what the brain can do? So it's wrong. What they should be telling you, and maybe they are and people aren't listening to it, we're using only 10% of our brain of what we know. That would make more sense. You can't say you only use 10% of your brain of, you haven't measured what your brain can do. So how can you know you only know 10%, right? So it gets interesting. This is my little spiel, but I want you to, because that's one of the reasons why I like the nervous system. I'm OBGYN, but the nervous system, amongst other systems out there, the nervous system makes so much sense. If you know that's what it does, remove it. Then how is this person going to present? That's the way you should be thinking for all your clinicals. Okay? Because they expect you to do that over there. But if you could do that now, then you're going in there and able to have your brain wired already for stuff that they're asking you to do later. Okay? So you won't struggle as much. Okay? So that's what I mean by interprets vision. Okay? It's not that they're blind. Temporal lobe interprets hearing, interprets smell. Okay? For the same thing. Okay? So if there's a stroke to the temporal lobe, the bell rings, he hears a dog bark. He's interpreting it different. Okay? It also deals with memory and emotional behavior. Okay? Insular lobe does language and has some part in the autonomic nervous system. But we'll talk a little bit about the language in a little bit. So this is where it all happens. I will not ask you hearing. Where does it actually happen in the temporal lobe? No, I'm not going to ask you that. But what I will ask you is, the temporal lobe does all the following except. I don't care where in the temporal lobe, but you should know that the temporal lobe does hearing, smell, well, that's the same thing, auditory. Okay, we'll go into other things too. You should know what the lobes, what they do. Where in there, I'm not going to ask you. Okay? Again, this is showing you the top view, emphasizing the central sulcus, the precentral gyrus, the postcentral gyrus. Again, the precentral gyrus is part of the frontal lobe. The postcentral gyrus is part of the parietal lobe, because the central sulcus separates the frontal and parietal lobe. Okay, functional regions of the cerebral cortex. Interesting stuff now. Not that that stuff wasn't interesting. All right, we have white fiber types. We can have fibers that are what we call association fibers. So let me show you. If this is going to be kind of a lousy brain. As lousy as it is. All right, so the right brain, so this is the, this is the right hemisphere and this is the left hemisphere. Okay? If we have fibers that stay within the same hemisphere, these are called association fibers. Commensural fibers, as you've learned about the gray commensal, right? Those are fibers that actually will cross through the corpus callosum. They're the ones that go like this. And communicate with the two hemispheres. And then we have projecting fibers. And those are the tracts. Those are the ones that are going up and down in the brain itself. They're the ascending and descending fibers. Okay? So we have primary cerebral functions. The motor areas, there are three. Motor areas that are going to do the voluntary motor functions. The sensory is going to receive the signals. And associations, it's going to integrate different parts of the brain. In other words, the postcentral gyrus is going to collect all the sensory, so sensory is going up there, and then it has to connect with other parts of the brain. Those are association areas. Until it finally says, oh, this is what we're going to do, and then it's going to send it off to the precentral gyrus, and then it's going to send it down as motor. Now, we have areas called Brodman's areas. Brodman was a gentleman, I don't know, 1800s or whatever, and he was able to map out a brain and know what everything is. Now, there's some parts you've already mapped out, like where, let's say, the temporal lobe, there's going to be the hearing over there and stuff. So the precentral gyrus is going to be where motor is going to be. So that's what I'm saying, but he actually went a little bit further. And not just, let's say, the postcentral gyrus is receiving all that stuff. Now, where is it going to go? From here, it goes to here. And what is that area called? And then from there, it goes someplace else. And what is that area called? These are called Brodman's areas. He mapped out the whole brain. He gave each one a name, and he gave each one a number. And there's a lot of them. There's like 45. We're not going to go over them all, unless you want to. No, okay. I'm just going to give you the main ones. Now, I'm not going to ask you to memorize the numbers. The numbers are a little bit helpful, though, because depending on what books you use, whether it's another textbook, a lab book, from another country, if you're in England, if you're in India, wherever you are, the numbers speak every language. Whereas the words, remember how I said, in order to master A and P, you got to know how to say one structure about 20 different ways. So someone might have called it this, but someone might have called it this. But it's going to be the same number. Does that make sense? All right? You have your name, and you got a Social Security number. You change your name because you got married, you still keep the Social Security number, no matter what country you go in. Right? So here's Brodman areas. These are the ones I want you to know. And we have primary ones, the ones that are going to get the information first, or send the information first. But then you got association ones that actually is going to help that. Right? You've got to have a lot of, if you have a like doctor's office, the doctor is the primary person, but he needs or she needs other people to help run it. You need the receptionist, you need the nurse manager, you know what I'm saying? You need other people to help run it, but the doctor is the one that's going to control everything. Does that make sense? But you have this association that's still going on. The primary ones I put in light blue. The association areas I put in pink. For motor areas, you have two primary ones. Primary motor and something called Broca, which we'll talk about. It deals with language. The association ones is premotor and frontal eye field. And I put the corresponding numbers that went with them. I'm not going to ask you to memorize the numbers, but if you're going to use a different book, or your lab book, textbook, whatever you're going to use, I call it premotor. Some books call it that. Other ones might call it, I don't know, premotor cortex or something else. But if it's the same number, it's the same thing. Sensory, there's a lot more, but it's easy to manage. primary sensory, which is really going to take care of touch. Primary visual, sight. Primary auditory, hear. Primary gustatory. What is gustatory? Taste. Primary olfactory, smell. So there's your 5 senses. Pretty easy. And then you basically have an association one with each one. So it's not hard. But there's more association ones that are out there. I don't want you to know those. I mean, I do want you to know them, but not for the class. There's also this obscene one called a Gnostic, which relates about 4 different areas. This is the integration of various areas to create thought. Just think about this. I'm not going to ask you about this, but just think about this. Thought. Why is it? How does memory work? Why is it that you remember certain things about grandma, and yet your sister was in the same room, same age, and she doesn't remember things? How is it that I could say something like levator labi superior solaki nazi, and all you think about is not the word, but the story that I told you, and you'll probably remember it for the rest of your life? How can you read something in a textbook and visualize it in your head? The thought. How is thought created? That's an amazing thing. We're just tissue. We're just ions. And yet it creates thought that can stay with you forever. You put this person in a coma, the thoughts are still there. Does that mean that they took his brain, they thought they could learn from it? They have it still someplace. Because we could almost crack it open and understand how this neuron synapses with another one. Maybe we haven't gotten there yet. How does thought get created? That's an amazing thing. If you really, you just take it for granted. Just go on, Dr. Gumar. But just think about it, okay? It's amazing. Ions leading to thoughts. Well, Gnostic is making you think. If you're agnostic, it's the you know nothing. People get agnostic on my exams. Right? Okay? And I wish I could do a whole lecture on thought because it's very interesting. I've had books about it, and it's still not clear. Right? It's amazing. And if you could do that and beat the system, then how do you memorize things? I've taught, like I said, I taught memory seminars, things like salty banana, that kind of stuff, how to memorize that stuff. And you guys remember how to do, remember the salty banana. So it can work. When people say they have a bad memory, that's not true. Everyone has a good memory. You just need to organize your memory to make those synapses happen fast so that you can remember things. Okay? Anyway, let me get off my podium with that. Questions?
So primary is where it goes initially?
Correct. That's the one that's collecting it first.
And then it sends it out.
To the associations. And there's more than these associations. There's other ones. I just want to put down, 1 or 2 for you to know. Okay? Question, Colin?
They're all unique looking, right? They don't all look exactly.
No, they're all different. And I wouldn't ask you where they are in the brain. I just want you, I want you to know what lobe they're in, but I don't want you to know where in that lobe. But they're in different areas. They're not just long, they're not round, you're right, they're different shapes. And Brodman figured that out. Unfortunately, we can't do that much now because that's being, we're playing too much Frankenstein. You can't just do a lobotomy on someone just to figure out what's wrong with them. Back in the 1800s, it's not something I agree with, but what was done is done, and now we can learn from that. Okay? All right, so this is just showing you those areas in a close-up. It's the same picture here, but now it's bigger. Okay? And like I said, I'm more concerned with you about what they do and what lobes they're in. Okay? But not where in the lobe. Take neuroscience. You'll learn it then. Okay? This is showing you a little bit more, but let me show you this. Again, this is the left side of the brain. This is now the right side of the brain. So here's the thumb of the boxing glove. His nose is over here. But I like this picture because it also shows you more detail about the numbers. All right? So this is the precentral gyrus. Here's the postcentral gyrus. And they have numbers over here. It goes out this way and this way. Here's the occipital lobe. This is all vision. All right, so let's go over a few of these. The primary motor. You dealt with this already. All right? It's our precentral gyrus. It's referred to as the primary motor. It's Brodman number 4. Again, don't worry about the numbers, just putting it there to be complete. It's in the frontal lobe, as you know from before. It's this green area here. That's in the frontal lobe. This has the pyramidal cells, right? This is where the cortical spinals begin, or they're also referred to as the pyramidal tracts. Okay? And this allows for voluntary motor control. It's where the cell bodies of the upper motor neuron, the first order neuron of the cortical spinals are. Okay? Questions on that? Now, something really interesting. Somatotropy of the motor. This is where the entire body is spatially represented in this precentral gyrus. The size of the portions of the cortex is proportional to the number of muscle motor units in that area. All right, let me show you what's going on here. Let me use the same picture here. Let's say I'm going to do a coronal cut right through the precentral gyrus. So I'm going to cut right through the green here, and this is what I have. So I actually cut right through the precentral gyrus. This area right here is the precentral gyrus, and it kind of goes in like that. So this is all the precentral gyrus. And it's going to have all pyramidal cells that'll go down into the as cortical spinal tracts. Now what this is saying is, on this band, on this gyrus, certain sections of this, and I don't have this memorized, and I'm not going to ask you to memorize it, but certain sections will control different parts of your body. For instance, this section over here, I don't know it by heart, all right, but you'll see a picture of it. This section over here is going to deal with, let's say, the tongue, can move the tongue. This section over here can move facial stuff. This section here, which is going to be bigger, is going to be your fingers, because there's a lot more dexterity you can do with your fingers. Maybe this small area will be your back, because I can't do this in my back. I can move it, but I don't have that much motor units on my back. I got a lot more motor units on my fingers. So what it's saying here is the somatotropy is basically, it's saying on the motor aspect, it's going to give you a designated spot for parts of your body, and it's in proportion to how many motor units you have in that area. My fingers have a lot more, so I'm going to have a more devoted place for that, a bigger place. My back doesn't have much motor units, so I'm going to have a smaller place for that. Does that make sense? It's spatially proportionate to the motor units in that area. Okay? So an example, my hand muscles get more devoted cortex portion than my back muscles. All right? Hands require many intricate movements to function. I could do that with my fingers. Can't do that with my back. Does that make sense? All right? That's why a surgeon, if he has the brain open, he could touch here, and if he touches in this area here and it deals with the hand might go up. He knows exactly where he is. Okay? We okay with that? All right. We'll get back to that in a moment, in a different way. We have something called the primary somatosensory area. This is the postcentral gyrus, the red here. Okay? This is numbers 3, 1, and 2. Again, I won't answer that, but why is it 3, 1, and 2? Because it's the way it was discovered. They saw this, they said, whoa, there's something behind it, we got to call it that. Why didn't they fix it? I don't know if I should bring that up to the people up there or not, but since they already saw 1 and 2, and maybe it's been out for 40 years, and then they realize there's another one, they have to change all the books then to make it go 1, 2, and 3. And that'll confuse things. So that's why I think the reason why they kept it as 3, 1, 2, because we were to change all the books and people referred to as 1. Now you're saying it's the old one or the new one? Which one are you talking about? So I think that's the reason why. Okay. So this is the postcentral gyrus, parietal lobe, and it's going to get all that information, as you saw before when we learned about the tracts. It's going to receive all that sensory. All right? So it's going to be the tracts, the spinothalamic tract, and the posterior columns, or the dorsal columns. Now, we also have a somatotropy of sensory. It works the same way here, but instead of movement, it's about sensation. Okay? The entire body, if we make this cut now in the red, in the postcentral gyrus, and it's over here, then we have certain places, the size of the portions of the cortex is going to be proportional to how sensitive that particular body is. For instance, I've done this before. I take two pencils together and have the points on the same level. I take those two and put it on my back. I'm only going to feel 1 point. This is what we call 2-point discrimination. I can only feel 1 point. Do it next time. Put that there. You're not going to feel 2 points depending how close they are. Even if they're really close, you're not going to feel it. But if you take them really close and put it on your lip, you'll be able to feel the difference. It's more sensitive on the lip. Okay? Now, for the most part, the somatotropy of motor will equal the somatotropy of sensory. There's a big section for motor of your fingers. There's a big section for sensory of your fingers. Okay? If you think about that. The lips, I can quiver, but I can't quiver my back. But my lips are also most sensitive compared to my back. Okay? Very rarely should it be the opposite. There is one, and sorry to get graphic, but it's the only one I could think of as an example that is not the same. The penis. Okay? The penis is highly sensitive. So on a sensory somatotropy, it's actually a large area. But on the motor, it's got a very small area. You can't make your penis go like that. Right? So that's what I'm saying. It's high sensation, but motor, it's very low. In fact, you don't even see much of the penis on the motor. Does that make sense? Okay? So, again, hand sensations get more devoted cortex proportion than the back. This hands have many more sensations than the back does. Okay? 2-point discrimination. Do that on the palm of your hand. You can feel the difference. The back, you're not. Okay, to put this all together, the homunculus. Ooh, this is a neat thing. The homunculus means little man. And someone came up with the ideas, if we could come up with a somatotropy of the motor and somatotropy of the sensory, and put the proportions of what is big up here into a little clay figure, so that you could actually visualize it, then that would help people understand what's going on. So that's what they did. They made this clay figure where, let's say, the back is going to be very small, but the lip will be very big. And we call this the homunculus. We have one for motor and we have one for sensory. They're going to be looking the same. All right? So the motor has the bigger areas with the greatest intricate muscle movement, and sensory is the bigger areas with a greater sensation. Overall, he looks like this. All right? His back is really small, his arms really small, but look at the hands. They're huge because there's more intricate movements, there's more sensation there. The lips, there's more sensation. The tongue has more sensation and movement. Okay? Does that make sense? All right? So that's what homunculus is. One of these days I'm going to have a student make this out of paper mache, put it on my fireplace mantle. People will look at it. You know? Okay, so that's the homunculus. So what I was trying to draw for you, here's the motor homunculus, so to say, somatotropy, kind of showing you where really all the places are. I won't ask you where those are. I would just want you to make sure you understand the concept of what it is. That's the motor, this is sensory. So you can see here sensory, the genital area is pretty big. But over here, a motor, it's not even existent really. Okay? But for the most part, it looks almost the same. Okay? And that's where a doctor can touch certain areas and get to know what he's touching by what the patient's telling him he feels. He could touch here and say, you're touching me on the lip. When he's really not. He's touching over here. Kind of neat, huh? Makes you want to go out and just, well, bring this down. All right, and this is another picture showing the same thing. Okay? Other primary areas. Primary visual does sight, primary auditory does sound, primary visual is in the occipital lobe, auditory in the temporal lobe, gustatory, which is taste, in the parietal lobe. All right, olfactory is going to do the temporal lobe also, does smell. Okay. Motor association, premotor. So these are association ones now. Premotor is going to be 6. So, if 312 was our precentral gyrus, the one just anterior to it is going to be 6. So that goes, so the information gets collected here before it goes into the precentral gyrus, right? Association. This area is going to control things like playing a piano. You got to learn how to do that first, but it gets to the point where you'll be able to do that and sing and talk to someone and don't even realize what you're doing. Like you're typing or writing or your signature. Frontal eye movements or frontal eye fields. All right, that's 8, which is over here. All right, it's going to control eyeball movement. Allows you to have eye scanning. You're driving and you don't even realize it, but you're scanning the whole area here to see where there's any danger or something where, you know, being a defensive driver kind of thing. Or you just reading that sentence up there, that's scanning. Sensory association areas. They're going to be in the parietal lobe. Parietal lobe takes care of sensation. So you'll have 5 and 7, which is going to be very close to, I'm sorry, 3, 1, 2 was over here, 4 was over here. I got the 2 mixed up. 4, that's what that is. Visual association, 18 and 19, right into the occipital lobe, which makes sense. Auditory, 22, is in the temporal lobe. That makes sense too. All right, interprets words and thoughts. Other association areas, prefrontal. Again, I won't ask you about numbers, but they're over here. It's going to deal with thought, reasoning, intelligence, and so forth. Gnostic is that one that's all over the place. It creates thought. All right? It's basically dealing with the 4, or at least the 3 lobes over there. All right? And integrates different things. We'll talk about that in a little bit. All right? So when it's damaged, it's agnostic. You're forgetful. Like I said, you get that with my exams. You know the material, but you just have a blank. You just have no idea. All right? So it could get very busy. All right? You don't have to worry about the tracks and where they're going. Just understand. I'm making you appreciate this brain is very complex. All right? Questions on that so far? All right, let me do language, and then I'll give you guys a little break. Won't take long. Language. We have two areas that deal with language. Broca's area and Wernicke's area. Broca's area is in the frontal lobe, and it's the ability to put words into sentences. You know what you want to say, but when it comes out, the muscles are just not controlling things properly. If there's something wrong with that area. I want to say, levator labii superioris alaci nasi. Because I know what I want to say. I've said it so many times, it's a routine for me. I ask you to say, even if I ask you to read it, you're going to stutter. Because you haven't really practiced using the Broca's area with that word. But you'll get the hang of it. Damage to this area, we call it expressive aphasia. Aphasia means an inability to communicate properly. You have this expressive, non-fluent aphasia. You know what you want to say, it just doesn't come out properly. You have a stroke to the Broca's area, and it comes out. You ask the person, how you doing today? What did you do today? And the person says, I fine, going on store. You see? And you've probably seen people in movies or your own family members who had strokes, and they have Broca's aphasia. All right? They know what they want to say. They realize that they're having a hard time saying it, and that's what happens. It becomes of a non-fluent aphasia. It's not flowing, it's non-fluent. Then we have Wernicke's area. This is the ability, and this is in the temporal lobe, this is connecting words and their meanings. You tell me something, you ask me something, but it comes in a wrong way. How you doing today? And the person, if there's something wrong with Wernicke's, then what we have is a receptive, it's fluent though, aphasia. It flows, but it doesn't make any sense with what you just asked that person. How you doing today? Money, 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 money. What do you mean money? Money, 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 money. Money, 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 money. I use money because I remember this guy Bill who had Wernicke's aphasia when I was a nursing assistant back in 1989 or whatever, and he was in rehab, and it was tough to communicate with him. He thinks he's explaining everything to you. He doesn't understand why you don't understand him. Okay? So my little mnemonic here is that if you have Broca's aphasia, it's broken language. If you have Wernicke's aphasia, you've got a wordy language. Okay? This is fluent, that's not fluent. You could pick and choose by just looking and talking to someone if they have some kind of aphasia, which one it is. Now, this is an interesting thing about the language because we're only saying verbally. But what about writing? What about sign language? You know what? It varies on the severity. Maybe it's a hard time speaking this way, but they can write exactly what they want to say. It might be really bad because the Wernicke's is so bad off. All right? So Wernicke's area is really a sensory thing. Coming into the body, it's all screwed up. Broca's is more of a motor because you know what you want to say, but it's broken down into you're not using your teeth, your jaw, your lips, your tongue in the proper way. All right? Does that make sense? Wernicke's and Broca's area. All right? They can't enunciate. Yes, if you know people that stutter, they have something wrong with Broca's area. Okay? And like I said, aphasia is difficulty in communication. So Broca's area is in frontal lobe and Wernicke's is in temporal. Okay? Do this on your own. It's basically expressive aphasia, and if you go step by step, it'll make sense here. It's just the one for Broca's. It's kind of a fun thing to do. You're learning all these words and where they are, and now you can see how they interact with each other.